Okay.
Good evening, everybody, and welcome to the 9th session of the Kolkata Anesthesia Academy, Apollo Gleneagles Hospitals, and the HCP Education Forum. As usual, we'll start with the poll questions, and Jyoti or Nob, if you're ready, we can just put in the poll questions, please.
Yes, sir.
So again, like before, if you have been here before, there is this question, and you will have 4 options to those. All you have to do is pick the most appropriate option. And again, it doesn't. It's not an examination. It's just to kind of make you also involved with this. Otherwise, in these days of webinars, it's very difficult because I'm not able to see you. You can't see me. Whatever. So a 55-year-old end-stage kidney disease on twice-a-week hemodialysis is posted for a gallbladder surgery. So what should be the preferred plan? Admit the patient on the morning of surgery, check the potassium. If it is less than 5.5, proceed for surgery. Or admit on the morning of surgery, dialyze without heparin, check the potassium, if it is 5.5, and then proceed for surgery. Or is it admit the day prior to surgery, dialyze, check potassium less than 5.5, proceed for surgery the next day. Or admit the day prior to surgery, dialyze without heparin, check potassium less than 5.5, and proceed for surgery the next day. What I would be looking for, or what is the most appropriate? It's not that you cannot do either of them, but what would be, in your opinion, the most appropriate a way to get around this scenario. So please put in whether it is 1, 2, 3, or 4, and we'll close the poll in 5, 4, 3, 2, 1, and 0, and go to the next poll. And this is very straightforward. Which of the following is not true for peritoneal dialysis? Peritoneal dialysis cycles should continue as far as possible till the initiation of surgery. The dialysate should be drained prior to surgery. The drainage of the dialysate leads to an hyperglycemic response. And peritoneal dialysis does not need heparin, which is not true. Dialysis should continue as far as possible till the initiation of surgery. Before surgery, the dialysate should be drained. The drainage of the dialysate leads to hyperglycemia. Heparinization is not needed in peritoneal dialysis. I think this is straightforward. 5, 4, 3, 2, 1, and 0. And we'll go to the next poll. Okay, the third poll is a 68-year-old female, end-stage kidney disease on dialysis, BMI is 32, has got reflex esophageal disorder. Her hemoglobin is 11.5, potassium is 5.9, and ECG shows peaked T waves. She's been posted for a laparotomy for intestinal obstruction. Okay, and so obviously this is kind of emergency. You don't have much time. So you need to intubate the trachea. So what will be your preferred neuromuscular blocking agent for intubating the trachea in this lady? BMI 32, gastroesophageal reflux disorder, potassium 5.9, ECG peaked T waves. So your relaxant of choice to intubate the trachea would be suxamethonium, rocuronium, atracurium, or cisatracurium. Again, this is very straightforward. All you have to do is pick up which one do you think is the most preferred neuromuscular blocking agent. Kidney disease, BMI 32, reflux disorder, potassium 5.9, peaked T waves, laparotomy for intestinal obstruction. We'll close the poll in 5, 4, 3, 2, 1, and 0. and go to the next poll question. Okay. A 65-year-old female, end-stage kidney disease on dialysis, needs urgent obstructive hernia surgery. So it's urgent. So you have to kind of get in within the next 6 to 12 hours. On examination, you find that her AV fistula access site is oozing. So she has manifestations of bleeding, and she's end-stage kidney disease, is on dialysis, and needs an urgent surgery. So for the bleeding manifestation, or to control the bleeding, or to take management of bleeding, what would be your preferred approach? Dialyze without heparin, give desmopressin, cryoprecipitate and platelet, or would be dialyze, desmopressin, cryoprecipitate and fresh frozen plasma, dialyze without heparin, desmopressin, cryoprecipitate and protamine, dialyze without heparin, erythropoietin, cryoprecipitate and platelet. So essentially what we are looking at, this is a patient with end-stage kidney disease needing an urgent surgery, emergency surgery. You find that the AV fistula access site is oozing. So there is a bleeding manifestation somewhere over there. And how would you take care of the bleeding? And you know you have to go in for the surgery very, very quickly. Heparin, without heparin dialysis, desmopressin, CPP platelet, dialyze, desmopressin, CPP FFP, dialyze without heparin, desmopressin, CPP protamine, dialyze without heparin, erythropoietin, CPP plus platelet. So which is the most appropriate response? We'll close the poll in 5, 4, 3, 2, 1, and 0, and go to the last poll question of the evening. Okay. This is again 69-year-old, needs a non-urgent hernia surgery. Okay, it's not an obstructive hernia or a strangulated hernia. She needs a hernia surgery. You find that her hemoglobin is 7.1. On investigation, she's not iron deficiency. She does not have coronary artery disease. So what would you prefer to do in this scenario? Would you admit the patient, transfuse 2 units of PRBC and proceed for surgery? Admit the patient, transfuse 2 units of PRBC, 2 units of FFP, 2 units of platelets, and then proceed for surgery? Or would you hold surgery, administer erythropoiesis stimulating agent? I'm sorry about this spelling of erythropoiesis. We're too much in love with erythropoietin and erythrocytes, and this extra E's appeared over there. We target a hemoglobin of 10 to 11 and then admit for surgery? Or is it hold surgery, administer the ESAs, target hemoglobin greater than 13, and then admit for surgery? So it's essentially about how are you going to manage anemia in a patient with ESKD on dialysis, not iron deficient, no coronary artery disease. Preferred approach, is it just 2 units of PRBC and go ahead and do the surgery, or 2 units of PRBC, 2 units of FFP, 2 units of platelet, proceed for surgery? Or you say no surgery now, administer the ESAs, target the hemoglobin between 10 and 11 and then admit? Or you say no surgery now, give ESAs, target the hemoglobin around greater than 13 and then admit for surgery? So what do you think is the most appropriate response? We'll close the poll in 5, 4, 3, 2, 1, and 0. So thank you for participating. We'll get back to the answers at the very end, and we'll just tell you about, as I said, the first agenda is to kind of, especially since this is a target for the postgraduate students, there will be something which will be a little boring for the practitioners. I think. So CKD, or chronic kidney disease, is a group of disorders which there is an alteration in both the structure of the kidney as well as its function, and it can have various manifestations. The operative word again is that it should be there for more than 3 months. So then